What is going on, everybody? It is Mark Cargil, lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician, coming at you with a episode to complement our last episode on upper quarter neurodynamics. I know Jared and I got winded, and we saw that this one was probably going to go a little bit, so we wanted to break it up a little bit in another bite-sized chunk for you guys to get some clinical value out of it. So, Jared, let's just dive right into it, because we talked about it as we started getting into the last podcast about, man, there's some things I think we can go deeper into that we see commonly in the younger population, new grads, DPT students, even maybe some practicing clinicians who might be new to maybe neurodynamic treatments. But this thought of like purposeful application of these tests, especially when it comes to the upper quarter. What are you seeing as far as really doing it with purpose and thought behind it and patient-centeredness behind it? What do you see going on in the clinic, and what are your thoughts on ways we can improve that in the clinic?
Well, so what I see a lot is that people, when they're approaching neurodynamic assessments, they're not necessarily being sequential in the way that they apply forces, and they're not being purposeful in the way that they do that. Trying to actually lock things down to a prime component that you're moving, so you can walk away with an objective marker for how sensitive to load maybe that neural tissue is. The first thing that I see is people, on average, do not pay close enough attention to their shoulder depression, right? So we know that on the radial nerve tension test and the median nerve tension test in particular, scapular or shoulder girdle depression is one of the key components. And I personally believe that it should be applied first. And then you go through the other components, whether, for the median nerve, it's elbow extension and supination and abduction and wrist extension and, elbow extension and all that sort of stuff. I see a lot of people just jerk a patient's arm quickly into this position, into that, ULTT A or whatever, or the ULTT median nerve position, and they go in one smooth motion and they kind of apply all the components at the same time, and then they don't really have a good objective way to say, hey, this is how sensitive that is, this is at what range of motion that becomes highly sensitive, and if I come back to check this later, I don't actually know where my mark was to see if I've made improvements in the ability of that nerve to tolerate tension loading before it becomes irritable. So I think that one of the things that really needs to be done is when you check a median nerve ULTT, for instance, you've got to apply your scapular depression, and you've got to abduct the arm with the elbow bent, and then you've got to supinate the hand and extend the wrist and use the elbow as what we call the sensitizing component, right? So as you're extending the elbow, it's the easiest joint to visualize, what range of motion it's at. So I've got my scapular depression, I've got my shoulder abduction, I've got my supination, I've got my wrist and hand and finger extension and external rotation of the shoulder. And then I'm taking that shoulder gradually and slowly the elbow gradually and slowly into more and more extension. And maybe that nerve becomes mechanically sensitive when the elbow is at 90 degrees of flexion. And then you do some treatment, right? You come back and you do some treatment to the neck, like we talked about in last episode, whether that's UPAs, whether that's a manual traction, whether that's a repeated motion where you do repeated cervical retractions or extensions or rotations or whatever it may be. And then you come back and you go exactly through that same process of systematically applying the loads to the shoulder and to the arm, and then gradually extend the elbow. And if all of a sudden now they're 30 degrees from full elbow extension, well, you've gone from 90 degrees to 30 degrees to full elbow extension, and your comparable sign demonstrates that you have made an objective improvement. And in our complete clinician supercharged, one of our students just had a question to me about, hey, how do I document real objective changes other than just like manual muscle tests and that sort of thing? And this would be a perfect example of an objective change that you can document in your in your note, in your paperwork to show, hey, we're making progress because this neural tissue is becoming less mechanically sensitive to load, which is ideally going to transfer over into less pain with ADLs. It's ideally going to transfer over into maybe increased strength in the rotator cuff or whatever it is, because you have a less mechanically sensitive nerve. And I can show that it's gone from 90 to 30, and then I can compare that to the other side to see what is about normal for them on that other side. And it's just, I see this being done a lot of the time in a really haphazard way, and not in a really purposeful, systematic test, retest, objective evaluation type of way. And I hope that that's coming through well, on the audio, on the podcast, that you can visualize that.
Yeah, no, I think you explained it well, and I think there's a few other things I would even piggyback on top of that, which I think you nailed it as far as some of the thoughtfulness and kind of really trying to be methodical in your application. This, especially with neurodynamics, you need to be consistent and reproducible and repeatable if you're going to get any decent data out of that. Like if you got, that's what I'll tell students, you need to look at where your pillows are, if somebody's legs are bent up or if they're not. I mean, these are all things that can affect tension in the system. So, I mean, just really being consistent with exactly how you position patients. The other thing, I mean, I'm 100% with you where people just kind of wail out into that position without any real methodical step-by-step approach where they can see which step of the process or things become insensitive, maybe have some measurables, like you said, with elbow range of motion and things like that. But the other thing that I'd say, especially when you're trying to rule out like shoulder, some folks are very kyphotic, for instance, and their scapular plane is tilted at a 45 towards the ceiling of the clinic. Yet the students and me, when I was early on, want the arm in full 90 degrees, like neutral horizontal adduction, where this person's just getting the anterior shoulder just yanked on. So I tell students, try to get things in the scapular plane for that patient, which for each patient may be different. But if you have them, if their scapular plane is 45 towards the ceiling and you got their elbow straight 0 degrees away from the side, like straight away from the side, then you're creating quite a load to the anterior shoulder, which can muddy the waters on am I getting sensitivity of neural situations, or am I just parking anterior load on the glenohumeral joint that could be a possible, local nociceptive tissue issue going on at the shoulder. So just being good with that as well. But I think what you said, it really, encapsulates it well as far as just being methodical with what you're doing and your positioning and and documenting, using it as a measurable and as a test retest for patients. Patients often are pretty like, holy cow, that was like zinging a lightning bolt at 90 degrees, and now you got me to, like, if not full extension, significantly better. And again, that's where I think too, like, a change needs to be something that's significant to the patient. Like sometimes we get, it's 5 degrees better, and yet the patient ascribes no change, nothing that's different in that. So that's just where I think let's make some significant changes, like where the patients, well, now some patients for various reasons might be very resistant. Maybe they're just fed up and distressed and not really feeling like there's change, and it's going to be a hard time to convince them that anything, not that we need to be convincing them, but this is where let their body convince them and then maybe you do throw some measurements at people to say, hey, this was 90 degrees, now it's 45. That's a significant change. Yes, we're still finding that sensitivity, but your body's telling me that, man, we're 45 degrees more, we've doubled, we've halved some of the sensitivity range of motion that you were dealing with earlier. So to me, that's a good sign. I think we're heading in the right spot. Some people need that kind of reassurance and rah-rah, especially when they've been through a really rough stretch, that they're not really keen to see improvement because they haven't seen it for a long time. But let's talk a little bit about lower cervical too, because I think we talked about this as well, as far as like when we start getting into the hand and looking at like repeated motions, lower cervical based treatments, and how those can impact a radial wrist, or even some things going into like the pinkies. The fifth digit on the hands is a common one. I'll see people say they're getting tingling and issues there. Yet the lower cervical being that kind of often mechanically sensitive load, because people are parking it in often sensitive loads. And again, I'm not going to get into the posture debate. Posture is only relevant if you can do something to it and it makes an observable, objective, and ideally subjective change in the patient's condition. So I get the whole forward head is not the next cancer to people, but it can be for the N=1 problem. I shouldn't say cancer, but it could be a problem for the patient if you demonstrate that changing that impacts their clinical presentation. Then I think we can make more justification of that. But blanket population studies saying that everybody should ascribe certain things obviously doesn't work. what do you think, and what's your experience been with kind of the value of getting into that lower cervical spine when it comes to looking down the chain of neurodynamics?
I mean, I think that anytime I have somebody present with symptoms in their hand, it's something that at least has to be looked at, right? You can't overlook this just because we know that you've got your kind of C6, C7, C8, dermatomal representation in the hand. So just like in the mid cervical spine with the lateral shoulder, you have to do some sort of mechanical assessment of the lower cervical spine, and whether that's repeated motions or whether that's CPAs or UPAs, whether that's overpressure even through the upper thoracic spine, right? We can't isolate the specific joint segments super well. So I can't say that, oh yeah, I'm really hitting, C7 right now. So what I try to do is look, at a range of maybe 3 or 4 vertebrae where, okay, this is upper thoracic and lower cervical, and oh, this is kind of lower cervical and mid cervical, and oh, this is kind of mid and upper. I kind of group those together. I think that we have decent enough evidence, and we have enough accessibility with our hands to those joints, that we could probably say we're getting 2 or 3 vertebrae together. But I try not to ever hang my hat on that I am specifically assessing the right sided C7 on T1 or anything like that, just because we're just not that good, and that's not how the body works. If you press in one place, guess what, some of that force disperses to other places as well, and you have referred hyperalgesia, where if you're pressing on one place that's sensitive, that might not be the place that's actually quote unquote the cause of that sensitivity. But this is, with the lower cervical spine, this is where I really like to get into repeated motions, especially retraction in particular, just because, as you alluded to, a lot of people tend to hang out in that lower cervical, flexion, where they do have the forward head posture. And, that's not, the forward head posture is not bad in and of itself, but if you happen to have a tissue that's sensitized due to, consistent and sustained overload, then, hey, let's change it. Let's move it a little bit. Let's get some blood flow. Let's get some mechanical stimulation. Let's do something different to it and see if that affects your symptoms. And if I do some really, really good repeated retractions where we get upper cervical flexion and we're trying to get some lower cervical extension, that sort of thing, and it affects symptoms, and whether it makes them better or worse, first assessment, I don't necessarily care. I just want to see that it is doing something, and that makes me go, there's something there. This isn't a Guyon's canal problem, or this isn't a cubital tunnel problem. Maybe this has got something going on a little bit higher up the chain, and that lets me zoom out and say, all right, I'm not going to just look at this person's hand. Now I'm going to look further up the chain. Maybe I'm going to do a ULTT assessment of the ulnar nerve now and see how sensitive that is, and pair that with my repeated motions exam, and pair that maybe with some other things like a supine manual traction to see if that affects symptoms. There's a lot of different ways that you can go with this lower cervical spine and presentation of symptoms in the hand. And I think that it's, as we've been beating a dead horse, it's being purposeful and it's being systematic, and it's not just throwing a bunch of crap against the wall and seeing what sticks. It's having a test retest approach. It's having a comparable sign. It's having a purposeful, we'll say, a purposeful, I don't want to say, well, I don't want to use the wrong word, so I'm not going to say that. It's just being really purposeful about that step by step and a piece by piece process to see if you can actually uh, draw some connections at a wider range that don't necessarily present upon initial assessment.
Yeah, I think just being purposeful, thoughtful, not tunneling in diagnosis, not falling into some of the cognitive bias and heuristic errors and clinical decision-making errors that we teach folks about in a lot of our mentorship and in our coursework, as far as like, you need to have a thorough process where you cast the net wide and you don't just zoom in, knowing when you need to zoom out, like Jarod said, and then zooming in too. And like we mentioned in past episodes, where it could be a little bit of neurodynamics and also a sensitive shoulder or wrist or things like that, where you might need to do a little bit of both. But again, you have a process that determines if both is truly changing things, or is it one where, hey, I'm looking down a neck here, there's nothing going on, I'm trying to make this a neck that is truly just a wrist issue. So I mean, you got to be careful on both sides of that coin, not to get too. And I will freely admit, and this is I tell students, that, this is my bias that I always try to keep in check, that I almost try to see spine more than I should when it's truly a local tissue issue in the extremity. But as long as you have a thoughtful cognitive, kind of debiasing process that you're constantly incorporating in your practice, this metacognitive, purposeful, reflective practitioner process, then you can ideally check those biases and make sure you have a clinical process that checks your biases, that doesn't just zero in on, I'm just going to treat the neck for everybody. You're going to say, hey, I have this bias of treating the neck for a lot of these things. I need to make sure that it's in fact doing something, or I'm not just trying to make it be this diagnosis versus being a contributor to that patient. So again, being a thoughtful, reflective practitioner, it seems, but again, it's easy to get in the grind. It's easy to get where the schedule's packed and you're just trying to keep your head above water, get your notes done and all that stuff. But I honestly think if you can employ this, which might be a little bit less efficient off the get-go as you get used to it and get good with it, but man, once you get running with this, would you agree with me, Jarod, that if you can start, then you get to treatment thresholds, you get to treatments that make changes a lot quicker as your pattern recognition grows, as you start seeing cases that the next time you see that case come through the door, are you going to stumble through those 4 techniques you just stumbled to get to the treatment that helped them the most? Or are you going to say, hey, been here before, seen this condition walk through my door before. I'm going to skip those 4 things that didn't help much for that patient in the past. I'm going to go right to that one that did. And then lo and behold, you're making changes a lot more quickly with people, moving them forward more rapidly in their care. Is that something that you've seen in your practice as well, Jarod?
Yeah, absolutely. I mean, there's the whole concept of clinical pattern recognition, right? And it was taught to us in a super mechanical way, right? It was taught to us in like, well, it's clinical pattern recognition of painful arc and Hawkins Kennedy test and that sort of stuff. But when you start looking through a different lens, you start developing a clinical pattern recognition for a wider range of things, right? You start developing a clinical pattern recognition for maybe the person's background, the person's thoughts, the person's emotions, their feelings and anxieties about it, paired with mechanical signs and symptoms, paired with, oh wait, I'm not just going to look locally at the joint. I'm going to look a little bit further out at joints above and below, or I'm going to look at the spine, or I'm going to look at other things that might be going on with a history of sleep, with a history of hyperalgesia and hyperresponsiveness to a lot of other stimuli in the past. And all of a sudden, your clinical pattern recognition becomes even better and better because you're pulling in a dynamic web of information from so many different layers of that human being, right? And then once you get really good at that, then you learn how to make it person centered within that clinical pattern recognition. And to me, that's what's being the complete clinician, right? That is being able to recognize the patterns at multiple levels while still being person centered and recognizing that that is an individual.
I like it. The mechanical level, the person level, the cultural level, the past experience level, their expectations level, the context they bring into the room level, the context you bring in the room with your biases and things that we talked about that you need to keep in check. But yeah, if you have a reasoning process that takes that all in and you start recognizing patterns that this patient with these expectations, this background, this level of distress, this sign of homeostatic system sensitivity. I have a patient right now who's just in a world of stress with some of the strain she's been on emotionally and financially with COVID and what it's done to her. And she's got neurodynamics, but it's everywhere and it's sensitive. And if I start, to me, it's like she needs to find, and we're trying to get her help because she needs help. Like, I don't think nudging on tissues. I said we can help and calm things down, and we do in session. But again, it's like then she goes to her life where life is not a very stable situation right now. So she's on board with some of the discussions we've had, and we'll have episodes where we talk about how do you recognize the human in distress that you need to maybe look a little bit more human system. And these are the folks that unfortunately fall in these medically unexplained system categorizations or chronic overlapping pain conditions, which isn't a bad thing. It's just that medicine doesn't do well because they try to put their finger on one factor and medicate it when it's a human problem these people have. But again, that's the reasoning you need to have with this. And that's where truly the complete clinician can recognize when it's more than what I need to do through a nerve or a tissue. I need to help this human in a situation of distress get the resources she needs. That my hands might be part of that journey and our exercise and our partnering with them, but maybe we need to enlist some other folks and look a lot more big picture at that human than, again, what lies underneath your fingertips. So good points that you bring up there, Jarod. Anything else you want to add to the discussion before we wrap up this episode for today?
No, just ask everybody to stay tuned when we circle back around to this topic and talk about neurodynamics in the lower extremity. And I think we need to get into a little bit more on dosing as well. So I think that the next episode will be really interesting for that.
Absolutely. Stay tuned as we continue down the neurodynamics rabbit hole. You can see Jarod and I tend to weave into some different discussions, but hopefully they were valuable to you. If there's any other discussions that you guys want to hear about, or clinical interventions or things you're seeing in the clinic that you want to hear us talk about, let us know. Or if you want to dive really deep into it, check us out in our Complete Clinician Supercharged course where Jarod and I are coaching folks one-on-one to really start employing this stuff that we're talking about, and creating that complete clinician, where we're kind of fed up, not necessarily fed up, but kind of feeling like the weekend course just isn't cutting it. You need to have somebody over your shoulder looking at what you're doing, giving you feedback, doing things where you don't have to move your life to a residency and sacrifice 20 grand in salary. You can do a much more efficient way of really becoming a really good practitioner early on in the game. So reach out to us if you have any questions about that. We're happy to have this discussion to see if it's a good fit for you. But until next time, make sure you join us for our next episode as we talk about lower extremity neurodynamics and some of the dosing involved. We will talk to you then.